Hi, and thank you for joining us for this Longhorns on the Hill event. My name is Rosa Flores. I'm a CNN correspondent and a proud UT grad, and it is my honor to serve as your moderator today. The University of Texas has been an integral part in the response of the COVID-19 pandemic, leading the way on life-saving research. And joining me to discuss all of this, two deans. First of all, Sharon Wood, Dean of the Cockrell School of Engineering, and Clay Johnston, Dean of the Dell Medical School and the VP for Medical Affairs at UT. Deans, thank you so much for taking the time to join us. And for those of you watching, please use the hashtag UTChangedMyWorld. So let's get to it. Dean Johnston, I was hoping to start with you. If you could kind of set the scene at the 40 acres for us. We're in the middle of the COVID-19 pandemic. What does this new normal look and feel like on campus?
Yeah, what does it feel like? Well, the campus is relatively quiet. There still are students coming and going on campus. Most of their classes are online, but things that can't be online, they are coming onto campus to do in socially distanced ways. Most of our faculty are also at home, not working in their offices. Sharon and I are in our respective offices today, but I think there are probably two other people in my entire building right now. So it is quiet. I think it's interesting. It's starting to settle down a little bit. There was real concern when classes first started that how long are we going to be here? Are we going to look like UNC? And yes, we did have a number of cases early on, and that did get us worried, particularly in off-campus housing. But now it's the number of cases among students has really settled down, and we've never really had many, just like a handful of cases amongst faculty and staff. Probably not COVID that they picked up on campus at all, but rather in their lives away from school. So it's kind of, it's a new norm. It's not quite as robust as that I'm sure you remember, Rosa, and that we all love to be a part of. But it's still, it's still vibrant and active, and a lot of engagement online.
Well, I share on the burnt orange glow just by talking with both of you today. Dean, what about your take? What's your take on the field of this new normal on campus?
No, it's very similar here in engineering with what Clay mentioned. We have all kinds of open study spaces for the students, and they're just not here. So it feels like as if you're walking through a building on the 4th of July, right, on a national holiday. When I've spoken to students, they might have a physical lab where they come in once every 2 weeks to perform experiments or something like that, but most of them are participating remotely. Many of them are here in Austin, but some have decided to stay at home with their families.
Yeah, and the purpose of this panel is to talk about the contributions that the university has made. And as we all know, the COVID-19 pandemic has infected more than 7.2 million. It has killed more than 206,000 people in America. All of this data is according to the Johns Hopkins University data that's available. And of course, one of the big concerns is and has been the shortage of PPE. And we know that UT researchers have been tackling this problem. And one of those ideas is, of course, 3D printing of masks. So, Dean, what I was hoping that you could start off by explaining that vision for us.
Sure. So when the pandemic first started, there was a real shortage of masks especially for the healthcare workers. And so we have a large maker studio called the Texas Invention Works, where the staff really focused on trying to use our available materials to provide those much needed supplies for the healthcare workers. So they were able to take some software that did imaging of your face and 3D print a mask that would fit exactly on your face. And then they were hoping to use something like furnace filters as the material that would go in through which you're breathing to provide the protection. So I think the early testing went really well, and they were able to get the suction they needed on these masks. But then commercial masks became available. So we got to the point where we didn't need to try experimental technology. I think, Clay, I'll let you take over, but basically you had what you needed, right?
Yeah. For now we do. We still, we don't, the N95 masks we keep running out of. So right now we're good. But I got to say, the masks that you guys were making, they fit far better than the ones that we typically use. So there were some real advantages to them.
And that was actually my follow-up question, because I remember reading and just talking and interviewing some medical professionals that was one of their concerns, the fitting of the masks. Are you able to talk a little bit about that, Dean Johnston?
Yeah, sure. So the masks only work as well as they fit, actually. So if you're coughing out above them or breathing in through them, then the mask isn't nearly as effective. And so, the fit is really important. So, the masks that engineering was helping with were ones that were to be used in really high-risk environments where maybe you're intubating a patient or you're in a patient's room who has very active COVID. And so those really need to fit well to be good. The other thing about fit, just to be real about it, is safety is critical, number one, but also people have to wear these things for hours and hours. And, we're getting lots of it. I mean, maybe you've seen pictures of people. That's real, the rash under the mask and the abrasions that they get from having it. So having a mask that actually fits is really a wonderful thing.
Yeah. Now, back to some of the research, we know that, of course, ventilators are another critical piece of medical equipment. And as you were mentioning, we have to keep in mind the fact that medical personnel that are on the front lines across the country are stretched thin as well. Dean Johnston, before we talk about the innovative research, I was hoping that you could paint a picture of and explain the need for ventilators during the pandemic.
Yeah, so thankfully right now we're good. And in fact, we never got to the point where we didn't have enough ventilators for our needs, but they did in New York. There were points in the outbreak in New York that was so fast and really, unanticipated. They couldn't get enough ventilators to care for all the people who needed them. And internationally, it is definitely a problem. And we're not naive enough to believe that we're out of the woods on this one, right? So it is possible that we will need more ventilators than we have going forward. So during the time, the worst times in Austin, and Austin was not the worst city in Texas, not the worst city in the US for sure, but definitely was hit harder than most American cities. We were to a point where we were having to convert regular floor beds, normal beds for patients, into ICU beds because we had run out of ICU beds. On a citywide basis, we were shifting people around the city to where there was a potential to open additional beds. And we were just getting ready to open up our convention center for additional beds as well. Fortunately, we didn't have to do that because things got in control just in time. So that was quite frightening. At that time, we did have enough ventilators, but the rural hospitals were very concerned and were sending us cases because they did not have enough ventilators. So they're the ones who really need a ventilator, and that's another great project that we worked on with engineering. So and Sharon can tell you more about that one.
Yes, please do. Right. So engineers love to problem solve, and I think across the country, many universities, they came up with ideas about these emergency ventilators. But I think what stands out about the work that was done at the University of Texas was the collaboration between Dell Med and the Cockrell School, and the way that we really worked together to make sure that this was something that could be used. And actually, we also engaged the Health Science Center in San Antonio. So Tom Milner was the faculty member in biomedical engineering who led this effort. And he used the motor from an intermittent wiper, so windshield wipers, as the mechanism to move a lever to squeeze the bag that would form the ventilator. So the bag is something that was used in medical for hand ventilation. And then the windshield wiper provides this mechanism of controlling it, the motor. So we're relying on a different, it's not using medical supplies. We're taking things from the automotive industry. And then Tom, working with the physicians, was able to really get it to be so it could be used for emergency purposes at a much lower cost than a typical ventilator. With some philanthropy here in Austin, we were able to get a manufacturer who's willing to manufacture these units for us. And I think, Clay, we're really close to getting FDA approval, aren't we?
Yeah, we are. It's been, the FDA was prioritizing this early on, and they're not now. So we've gotten kind of gummed up at the FDA, but we've addressed all their questions after several rounds of review. And so, yeah, we anticipate that it'll be approved. And it's not just a basic ventilator. It actually has all the major functions of a normal ventilator, which is really remarkable given how it was constructed. So we have a bunch of rural hospitals that have ordered them already and are waiting FDA approval for us to send them to them. And that internationally, it could be really valuable as well. It costs less than $2,000 to make, compared to them typically spending $30,000 or more on a ventilator.
And there's this video online that I was able to watch. It's fascinating to watch. And one of the things that really captivated me was the fact that there are so many medical professionals out there that are stretched thin. And Dean Johnston, you could probably explain it a little better than me, but if it's not done mechanically, this would involve an individual actually physically pumping oxygen into a patient.
That's right. And it's not only is that arduous doing that over and over. You can't do it with the kind of precision that you really need in these patients who have really, really fragile lungs. Any extra pressure on the lungs can create damage that they may not be able to recover from. So, getting that replacement of a person is absolutely critical.
And the use of the windshield wiper motor, I thought was fascinating. Dean Wood, could you talk a little more about that? Because as Dean Johnston was just saying, there's so much precision that needs to be included in this process that, we see the windshield wiper when we drive around, not even thinking that's a life-saving device now that could be used.
No, that's right. And it's well tested. Right, so it's been used in millions of automobiles around the world, and there's a ready supply of them. So it addresses a lot of different issues. And I think that's the kind of problem solving that engineers like to do. They see a problem and they see something else from a different area, and they put the two together to come up with a great solution. And so Tom and his team just did a wonderful job in the prototyping. I can remember I got the first video and sent it to Clay, and he goes, well, it has potential. And it really did.
It's better than me doing it.
Right.
Yeah, I think the other part too, Sharon, that we should point out is that, creating a prototype is great, but then figuring out how you're going to get to a manufacturer, how they're going to manufacture it, and then what's the sort of business model to support this thing to propagate it. And that's also been part of our partnership, is to figure those things out. Unfortunately, we got directed philanthropy that has helped us to underwrite these initial costs. But now that part's done, we can really think about how the typical what starts here can actually happen with this device, right? So, and we think it definitely has huge potential.
Mm-hmm. And so, where is it now, Dean Wood? In the process,
as Clay mentioned, we are waiting on the FDA approval, and then I think we have a manufacturer to make. Is it 50?
Yeah, but the manufacturer can quickly gear up and make a lot more. But we already have orders for that. So you know, those rural hospitals are asking for them.
Oh, that's wonderful. Now, Dean Johnston, one of the things that I wanted to chat about is, of course, the Dell Medical School is very young. It's been open for about 4 years, correct?
Yeah. We've graduated our first class.
Congratulations. Yes, congratulations. And so one of the things I was very curious about is the fact that you are responding at a time of a public health crisis in the middle of a pandemic. And so I wanted you to share perhaps some of the contributions that you are most proud of, how the school and yourself have been able to participate in that public health response.
Yeah, sure. So I mean, I think the realization is, I mean, and it's obvious across the United States, is that we haven't really supported public health very well at all through the years, but certainly nowhere near the level that would be required to handle, something as serious as this pandemic, right? The tremendous impact that it's had on individuals, on society, on the economics, on our healthcare system, all of that incredibly complex, and many levers to change that have really important outcomes that are somewhat difficult to predict. They require a depth of understanding of the science in order to get there. So we're a medical school of UT, but also of this community, right? So UT funded us, but also this community did. They voted to increase their property tax to bring us here. So we are already very linked to this community, and we talk about the importance of creating a model healthy city. And so we have those partnerships. That's part of what we do and what we're about. So, Austin Public Health can't do this stuff by itself. No city public health entity can do it. No statewide system has been adequate to handle this. And so our goal has been to partner with the city where we can and do things independently that support their work. And we've done that in a whole variety of different areas. I mean, I think the bringing more science to decision making is one area. That's not med school, just med school. We're part of that, but also, Lauren Myers and her work in the modeling has been critical in that response. But then also, we're in the throes of the clinical care as well. So we're also looking at how to optimize clinical care, and that has been really interesting as well. So I would say, you asked me what's the greatest areas of impact. So just, real quickly, I'd say I'll give you 3 quick examples. One is one of our students created a nonprofit that's called Good Apple, and other students have helped, and a faculty member helped them to put it together. And it takes food from local farms, boxes it up, and sells it to people, and then for everyone that it sells, it gives a free one to somebody who can't get that food. And in COVID, that has been absolutely critical. So it's kept people at home. It's kept people who can't afford good food. It's given them fresh, local, organic food. And now they've delivered over 1 million pounds of food. And amazing. This is run by a student. The CEO is a 4th-year medical student. So, pretty remarkable. The second would be in the homeless. So this is another one where we got help from philanthropy, and we totally needed it. We knew that was going to be a very vulnerable population, and so we designed a whole program to kind of wrap extra supports around them. We worked very closely with the city to identify housing options for some of them at high risk, but then we had extensive testing out where they live, under the bridges, and all of that, in the woods, and also in the shelters, and have kept the positivity rates in the homeless extremely low. So I don't know that there's any city that has as healthy a homeless population as we do right now through the COVID. So just a really remarkable, and that was work we did with Central Health, with the city, with other partners as well. So it's been, a wonderful demonstration of what you can do when you work together. And the third, sorry, I'm trying to say I'm fast. The third is is the work in the hospital. So we early on determined that given the expertise that we had, that we ought to turn our primary adult teaching hospital, which is the Dell Seton Medical Center at UT, we ought to turn it into a COVID center of excellence. And so we've aggregated COVID cases preferentially there. It's not the only one in the city, but it's been a major one. And then we sort of figured out all the protocols and did a bunch of our own research and all these wraparound protocols. Our case fatality rates, so coming in with COVID, the risk that you die, are substantially lower than any other hospital in that we know of. They're compared to university hospitals across the country. They're less than half of what a typical university hospital has had, and we haven't found one in Texas that has as adjusted case fatality rates as low as ours. So remarkable outcomes, and so those are some examples. And I think they demonstrate kind of the spectrum of the work we've been doing.
And Dean, what about you? What are you most proud of?
So I was looking at a list about 2 weeks ago. I think we had 60 faculty members get new types of research grants to address many different aspects of COVID. And it really ranged the spectrum of all the research going on in the Cockrell School. So we have an electrical engineer who comes up with a new type of sensor that can be used to test both for COVID and for influenza and test simultaneously. So it's a prototype, but it's something that could be of great importance moving forward. We had faculty members who are looking at possible vaccines, and many of those vaccines have to be stored at really low temperatures, so freezers, and could they stabilize the vaccine so it can be stored at room temperature, which would make distribution much easier, especially as you're going to many of the lower socioeconomic areas. We had other faculty members who were worried about the impact of cleaning products and how that could influence permeability in the masks that some of the custodial staff are wearing, or is there a way to enhance the mask by using soap to try to catch some of these materials before they penetrate in through it. So I think it really is completely broad, that engineers like to solve problems, and they look at it from what are they working on and how could they come up with a solution that would help the entire community. So I'm just thrilled that the faculty are doing such a great job and being so in trying to solve problems that can really help the society.
Yeah, and one of the other things that stood out to me too was how, because UT now has a medical school, and because we're in the middle of a pandemic, you're able to collaborate with a medical school that is responding to COVID-19. So, Dean, what I was hoping that you could chat a little bit about how it's been for you to collaborate with the Dell Medical School.
So I think that's been one of the things that the faculty really appreciate since the Dell Medical School opened. One of the things Clay started very early on was called the Texas Health Catalyst, where they identified problems that physicians were facing and reached out to engineers to try to come up with solutions. And then they would help move that through toward commercialization. And so we have been working together for more than 4 years, really, as they were just starting the Dell Medical School, but our faculty were getting involved in this problem solving. And so we've had a number of companies spin out based on these types of ideas that have gone through that Texas Health Catalyst. So, and then the contacts that had been established in the community are what allowed us to move forward quickly with developing the ventilator that we talked about earlier. So I think it's been a great, we have worked very well together, and I think the faculty in engineering really appreciate having physicians and the opportunity to work with them in a clinical setting here in Austin, rather than having to go to Houston or Dallas, which is what they did before.
Dean Johnston, would you like to add a little about
Sure.
that contribution and the collaboration?
Yeah, I mean, this is one of the great things about being at UT, right? We have so much depth in so many different areas, so many smart people, creative people, and working across schools is an opportunity for all of us to improve what it is that we do and have greater impact. And so I've definitely been so thrilled with how well that's gone. Our work with engineering is a great example of that. I think engineers and clinicians think they want the solution for the problem that's in front of them. Yeah, we have basic scientists. They're willing to wait years for a health impact for what they're working on, but there are plenty of physicians who want the answer now and a solution now, and so that culture merges really well with us in engineering. And we have a lot of creative people in the med school. They got a lot of creative people in engineering, and putting them together, you just see wonderful things happen. And again, that's been true even across the board, whether it's communications or fine arts. Even we've got really, really interesting things going on. UT is an amazing place.
Yeah, and Dean Wood, you mentioned briefly on how your college had contributed to the vaccine research. I was hoping that you could add a little more.
Yeah, we have several faculty members who are working on therapeutics. Some of them are looking at developing new types of vaccines, and others are looking at trying to stabilize them, and as I mentioned, to try to make them be able to be transported at higher temperatures to reduce costs and make them more available. So we actually have quite a few faculty members who are interested in these efforts.
Mm-hmm. And Dean Johnston, anything you'd like to add about the contributions that UT is making on the vaccine research side?
Well, we were the place that first identified the spike protein, right, and characterized the spike protein, and that characterization has been absolutely critical to the development of vaccines. And we did that before there were many, or really, if any, U.S. cases. I mean, that was like unbelievably fast. And
that was in the College of Natural Sciences.
Yeah, that wasn't Dell Med, it wasn't engineering, but that was UT, and that's it shows how fast everything's working, how much work is going on, and we can continue to contribute where we can to that vaccine research. Is now in the hands of big pharma, really, and that's where it should be. The phase 3 trials are rolling forward, and hopefully we'll start seeing results come out. And probably it's going to be a couple months, but fairly soon.
Yeah, one of the other things that I'm really fascinated by is how COVID-19 has been such a huge disruptor. So much of just life has changed, including how patients receive life-saving medical care. So I was curious to ask both of you the same question, and Dean Wood, if you'd like to start, what has changed during COVID-19 that you think is here to stay?
So I think, as we discussed earlier, the students are really staying away. So they don't have the community that they had. And so I anticipate that we will still have in-person classes moving forward. But I think what the barriers have been reduced on getting outside experts to come in and give a seminar. They might not travel, they might have a conversation just like we're having today. So I think we'll be able to take advantage of expertise from around the world and integrate that into our curriculum. I think that's going to be a big change moving forward. It won't be all personal. And then I think the faculty, well, I was going to say, I think when Dell Med started, they really took the traditional medical curriculum and tore it up and put it back together in a different way. And I don't think we will be as aggressive with that in engineering or on the academic side of UT, but I think that the faculty have that option now. they can determine what best really is done in person and how do you make the improve student learning by enhancing those interactions. So the kind of rote memorization that Dell Med is no longer embedded in the classroom. I think that will be the same sort of thing that we see, that we'll have more of that being posted online or being done in advance of coming in and having the classroom experience really focus on the discussion and the deeper learning of the material.
And Dean Johnston, what about you?
Yeah, I mean, what Sharon said rings true for me as well. I think this is, this is related to, what we were trying to see happen in the evolution of medical education, and I think that is likely to continue. And on the patient care side too, things are really different. So early in the pandemic, people just didn't come in for visits at all, and that a lot of care that people should have gotten, they didn't get. And they're starting to catch up now, but many people are not catching up. Cancer prevention treatments, vaccines, a whole variety of different, and even a treatment for acute things. I'm a stroke neurologist. Stroke rates went down, and it's not that the stroke rates went down, it's that people just didn't come in after their stroke, and that's not a good idea because we've got great treatments for stroke now. So for us, we quickly pivoted to telemedicine. So for a while there, over 70% of our visits were telemedicine visits. And it wasn't easy for some people to figure it out, to make sure they had adequate internet or to figure out how to use Zoom. So we converted to a very simple platform, Zoom, which all of us now I think are more than familiar with, and it worked. And now, even in things where you'd think being in the same room would make a really big difference to patients, like psychiatry, the patients are telling us they don't want to go back. We can see them. We've gone to about now 50-50 in-person versus telehealth. But before this, we were probably 5% telehealth, maybe 10. So this is like a huge shift. For us, that's really exciting. And this isn't unique to us. This is happening across the country. But we have a different way of providing care. We sort of wrap care around a person and try to provide all the things that they would need for a specific condition and care for the full person. And also we try to not have so much waste in the system. There are a lot of unnecessary procedures, diagnostic procedures and therapeutic procedures that are done because they're kind of driven by the finances of healthcare. We think that's not in patients' best interests, so we've taken that out. So telehealth actually allows us to get in front of more primary care docs and patients in a really convenient way and get them started on a pathway that's going to achieve a better outcome for them without wasting their money or society's money in that care. So for us, it's actually, we see it as a real way to expand our reach to get more effective care to more people.
Yeah. Now we're starting to get some audience questions, so I'm going to go ahead and start reading some of those. And just to remind all of our audience, if you are using Twitter, please use the hashtag #UTChangedMyWorld. So this question is for both of you, but Dr. Wood, if you'd like to start. The question is, what do you think we've learned from this pandemic and our nation's response to it? So as you look into the future of your research, does that planning for the next pandemic change some of the research focus and in what areas?
So that's a really good question. My background is a structural engineer, and I started my career studying earthquakes. And so I view this pandemic much the same way as I viewed the earthquakes earlier in my career, where after each earthquake, a team would go in to do reconnaissance and realize where our standard structural engineering approaches had not worked, and then figure out how to do things better moving forward. And so I think any type of natural disaster, and I'm going to put the COVID pandemic in that same characterization, it really causes you to reflect on the assumptions you made going in. I think back to us on campus in early March when we thought that COVID was nowhere close to us and we were, it was something that was distant, and then within 2 weeks, suddenly our university was shut down. So I think it forces us to think a lot about contingency planning, and it's something that is really hard to do because the immediate needs are always tend to trump the longer term planning efforts. And so that might be whether you should design your buildings for the earthquake and needs, or fund the schools right now, right? So I think that same type of discussion is going to be very similar as we move past this pandemic. I think it's really highlighted the fact that that with our global economy, we have to expect that these types of things will happen in the future. So I anticipate there'll be just much more planning about much more contingency planning moving forward.
Mm-hmm. And Dean Johnston, what about on the medical side?
Yeah, I think, well, first of all, it's definitely revealed the importance of public health and the public health institutions, which again, we've underinvested in. Other countries end up spending a whole lot less on healthcare because they invest more in public health. They prevent illness, and then they can respond to illnesses like this more effectively. So I think we've learned that we've underinvested in it. Whether we'll actually do anything about it, I'm not sure. We don't, we've not done that. It just, as Sharon says, it's we feel guilty about not treating somebody who shows up in the emergency room, but we don't seem to feel guilty about preventing their trip to the emergency room by actually treating them before they waste all our resources on arrival and are already sick at the time of the emergency room. So it hadn't worked yet for us, but maybe COVID will help us to realize that. The inequities in health are huge, right? And COVID's really revealed that as well. And again, I'm not sure. I think it's important for us to understand that that's part of our society, and how we respond. I think will be interesting. I'm not sure what that response will look like. And then for the next pandemic, yes, we will have another pandemic. Will it be in our lifetimes? Well, this was about 102 years or 101 between the last major international pandemic and this one. I don't think it will take 100 years for the next one. Just as Sharon said, we're much more global now. We interact more, and I don't think just eliminating the live animal fairs or markets is gonna do it. That's just that's not enough. These things will crop up, and we'll have more. So I'm very impressed with how quickly we created a vaccine. It's just really remarkable. Even though I know everybody wishes it had been even faster, I think we can probably trim even more time off of that, so that we really are up and ready to go even quicker the next time around. I think vaccines are going to end up being really important. I'd love it if we had new approaches to viruses that gave us more confidence that antivirals would work. Drugs, just like we have antibiotics for bacteria. And obviously people thought maybe hydroxychloroquine was one of those. It was not. It didn't do anything other than cause arrhythmias. But can we do more work and find ones that can impact more viruses? That would be another great area for us to work on.
Mm-hmm. And I know you touched on the inequities, and I'll take a few more of the audience questions, and then I would like to ask both of you, because I noticed that both of you issued statements back in June speaking about those inequities and how COVID-19 really revealed the deep roots of some of those inequities and how people were impacted, real people were impacted by that. So we'll do a few more questions and then we'll go back to that. And this question is for both of you also. And the question is, what would you tell a freshman in your college about how to make the best of this new virtual world? Dean, what if you'd like to take that one first?
Yeah, the students have been asking me that frequently, so I've been thinking a lot about it. I think the biggest disadvantage those students are facing is they didn't have a community here. So they're feeling much more isolated. So I've been telling them to try to take advantage of things like tutoring that we offer. The student organizations are still meeting, even though virtually. So participating in that and just getting involved to the extent possible. I think mental health has been something that's been a real concern for the engineering students recently because pressures are so high and now they're even more isolated. So we're trying to increase the availability of that for our students also. So don't be shy to ask for help. Maybe that's probably the most important thing. We believe all our students can be successful and will be successful, but they may hit bumps along the road, and so we want to help them through those.
And Dean Johnston?
Yeah, well, for us, we don't call them freshmen, of course. We just call them first-year medical students, but because they already did their freshman year as undergraduates. So what I tell them is, yes, we do have much more online than we had before. Just kind of hang in there. But I actually think for our medical students, this is a really important time to be learning, to be here. They can see what happens in the profession when we are really critical to society on the front lines of responding to something that we don't really understand and that is overwhelming. And them seeing how important new information is, new data, new studies, how quickly we can adapt to it, how we work in teams, how we support each other, how you find resilience in that, even when your patients are dying, and also, get a sense of time limitedness, right? So that's another thing that our students are less clear on. This isn't, the rest of their lives, we hope. That there will be these hard times, and particularly in our profession, and we will work through them, and that's when you rise up and you do the best work that you can and that society demands of you. And being in these positions is an honor, even if it also is incredibly fatiguing. That has to be combined with the fact that, just as Sharon said, for our students and for all the people around them, burnout and anxiety, depression are really high right now. It's really hard to lose, the young people, families that you connect with, and to do that day after day. That's really, really difficult. And then not having the social environment to work through that also becomes, it exacerbates that issue. So we've got to sort of bring those things together. This is a great time to learn. It's also a really hard time to learn. We do that together. Resilience is really critical.
Yeah, there's so many stresses right now, so many added stresses. Okay, so the next question is also for both of you. This person wants to know a little more about how the research, because how you've been talking a lot about the great research that's being done at UT, if that research is connected into the classroom, or how it's connected into the classroom. Dean Wood, if you'd like to take it.
Sure. So I would say about a third of our undergraduate students at any given time are doing some sort of independent study where they're working with faculty members in their research labs. In some departments, it's really part of the culture, and students as in their first or second year are actually having active roles in the research programs. So the advantage of being at a research university is that the faculty are at the cutting edge of the technology, and that they're bringing that into the classroom all the time. So if there's a new development, let's say Dr. Menard is working on stabilizing these vaccines, she's able to talk about it in her class. And so the students hear about it as it's happening. And so I think that's one of the huge advantages of being at UT at a major research university.
Yep, and similarly, the students hear about all of it. They hear about it. We do less in the classroom than engineering does because we're more on clinical rotations and in others' classrooms. We have in our third year, a lot of our students go and get masters somewhere else across the university. MBAs or in engineering or in a whole bunch of different areas. And I would just also say that our students are involved in that research. So they're far enough along that they can be important team members in that research, whether it's laboratory-based or clinical research.
Mm-hmm. And I believe that concludes the questions that we have. But just to wrap everything up, I do want to go back to something that you mentioned, Dean Johnston, about the inequities that the COVID-19 pandemic has really showed. And both of you released very powerful messages. I felt I went back, by the way, and researched a little bit about some of the posts that you had made, and I know that Dean Johnston posted a blog back in June. It was titled "A Call to Action," and you really expressed a lot of frustration over that topic. And I'll quote a portion from your blog. It said, "We watched as the inequities have gotten worse around us, resulting in so much illness and death delivered through institutional racism that is tied to poverty and differential work protections," end quote. And as the title of it suggests, I'm wondering what your call to action is, again, as we close this panel discussion, and I'll ask Dean Wood a similar question too.
Yeah, so I mean, for us here, for me personally too, all the public discussion about racism and the impact of racism, mostly in policing, but it's really opened up a broader conversation about existing racism in America. And at the same time, the realities of what was going on with COVID on the ground, those sort of hit, and really intertwine. And for us, yes, we would love to see racism go away, right? Like everybody. But for us, the real place where we're responsible is in the health inequities that exist and have forever in the U.S., even before, and in every country, and to try to think about how we might address those. And so, we had already been focused on this as a major issue. The quickest way to create a model healthy city is to deal with the inequities, because the reality is, if you look at Austin or you look at any city, most of the people are quite healthy. They get access to good health care, to good food, they can exercise, they've learned how to be healthy, they understand their health conditions, they follow instructions and all that. And then there's another group that's marginalized in a lot of different ways. They're the ones who are unhealthy. They are disproportionately impacted by disease. They're more likely to be uninsured, but that doesn't mean we don't pay for them from a societal perspective. We pay more for them actually because we pay for them in our safety net system, and then when they hit the hospital, we all pay for them. So we let those inequities exist, not to save money, but because it's convenient to do so in our system. So for us, it's a more pragmatic realization too, that it's not actually, it's in everyone's business interests, not just social justice interests, to address these health inequities. And then when we do that, we have to look at the underlying aspects that got us there. And institutional racism, structural racism, those are critical factors that must be examined, as well as others. But in Austin, the history is quite clear about how this stuff was set in motion, and you can't just sort of snap your fingers and say, it's gone. This is hard, long work. Mm-hmm. But I can tell you, on my desk is our action plan for. So it's always here. I'm thinking about it all the time, and multiple steps about how we can begin to address some of these issues.
Yeah, and I really do think that COVID-19 really exposed a lot of that as it hit Latino and Black communities across the country. And so, Dean Wood, to you, I saw the message and the post, the statement that you posted as well, and I'll quote a portion of it as well. And the quote is, and this was following the death of George Floyd in early June is when you posted this. You said, quote, "I am filled with sadness, anger, and outrage. Racism and violence have absolutely no place in our society, and now more than ever, we must use our voices and stand together to implement change," end quote. So again, in the context of the COVID-19 pandemic and everything that is being done by your colleges and the university to try to conduct research and so in this call to action, I'm wondering what your call is.
Right, that's a really good question. So I think we also have a plan. Unfortunately, I don't have it on my desk to show you, but we have really been focusing on trying to help all of our students. I think one of the things that hit me the most was the conversations we had with our Black students and how they feel that their contributions are marginalized on a daily basis. And that is a culture that we are not willing to accept in the Cockrell School. So we've started additional training programs for the faculty to make sure that people are aware of how offhand comments that they make are interpreted and how harmful they can be. We also are trying to really focus on our students who have the greatest needs. So students who have housing insecurity or food insecurity, and providing additional resources for them. I think some of the alumni who've been most successful coming out of the Cockrell School came from incredibly humble means. They grew up without electricity or a cabin that had a dirt floor. So we've had tremendous success in engineering by helping to move entire families out of poverty. And I think that is a challenge that we're willing to accept moving forward. But we also recognize that because of these systemic inequities, those students are going to need more assistance making the transition to college. And that's where over the past few years, we have been placing a large portion of our efforts. The entire university has been focusing on student success. And then last year, or starting this fall, the university has put in a lot of additional scholarship money. So students with families with household incomes less than $90,000 get full tuition covered through these scholarships. So I think we have an obligation to the state of Texas to educate the students in the state. And that means all of the students in the state. There's a huge amount of diversity amongst those students. So trying to provide financial resources so that students are not limited in their options is something that has been incredibly important for the entire university. And so those are some of the things that we're doing right now in the Cockrell School.
Thank you so much to both of you for your contributions and for taking the time to chat with us today. So thanks again to our panel, Sharon Wood, Dean of the Cockrell School of Engineering, and Clay Johnston, Dean of the Dell Medical School and VP for Medical Affairs at UT. Again, I'm Rosa Flores, your humble moderator. Thank you so much to you, our audience, for tuning in today. And now I'd like to turn it over to the Texas Exes for a few updates.
Thanks to our panel today for the great conversation about UT Austin's research. From the Texas Exes, we want to thank everyone who's tuned in and learned this week with our alumni and university leaders during virtual Longhorns on the Hill. Today, there are 2 more actions you can take to support the university. By texting Longhorn or Story to 52886, you'll receive action links. These action links are also accessible on Texas Ex's social media. Whether you share your Longhorn story on your personal social media today by hashtagging UT Changed My World, or use our action template to share UT Austin's higher education priorities with members of Congress, all actions show that our alumni step up during important times for the university. Thanks again for tuning in to Longhorns on the Hill, and hook 'em.